Hello everyone. I am myself Dr. Rajesh Gubba. I'm the general medicine educator. So in this particular section, I'll be doing a quick rapid revision of the very important topic, that is syndrome of inappropriate antidiuretic hormone. So it is a clinical condition where there is inappropriate secretion of the antidiuretic hormone. Now, because of inappropriate secretion of the antidiuretic hormone, there is increased water retention, right? Even though there is increased water retention, you don't have a dilution effect. Why? Because there will be activation of the compensatory mechanisms. So what are the compensatory mechanisms that gets activated in response to increased water retention is there will be inhibition of renin-angiotensin aldosterone system, and there will also be release of the atrial natriuretic peptide. So because of the inhibition of RAS and release of natriuretic peptide, you will not have the fluid overload. These patients, they will be having euvolemia. But in this process of the activation of the compensatory mechanisms, that is inhibition of RAS, aldosterone is not synthesized, release of atrial natriuretic peptide, there will be excretion of sodium along with that water. So these patients, they will be having hyponatremia. These patients will be having hyponatremia. So that is the reason why the serum sodium levels that will be reduced. But what will happen to the urine? It will be a concentrated urine. Why? Because in the urine, the sodium is being increased due to the inhibition of RAS, because there is no aldosterone, and at the same time, there is release of the atrial natriuretic peptide. So if you take this pathophysiology, there is excess amount of the ADH. This will cause increased water retention, and this increased water retention will cause, this will cause the low serum sodium, and this low serum sodium is mainly because of the natriuresis, which is caused by the release of the atrial natriuretic peptide, and there is also suppression of renin-angiotensin aldosterone system. There is also suppression of renin-angiotensin aldosterone system. So these patients, initially there will be dilution effect, but later, because of the activation of the compensatory mechanisms, they will be having natriuresis, and that is the reason why we consider this as euvolemic hyponatremia. These patients will be having euvolemic hyponatremia. So initially it may be dilution, but later it is euvolemic, right? Now, so if you take the types of the SIADH, so one is you have the classic form of the SIADH, right? One is you have classic form of SIADH. The other one is nephrogenic, right? Nephrogenic SIAD, right? Nephrogenic SIAD. Like what exactly happens here, I'll tell you. So this includes the familial forms due to mutation in the V2 receptor or due to mutation in the GNAS gene. Now, in case of the familial form, right? So in case of the familial form, this familial form is due to a V2 receptor mutation, right? Or it is due to G protein mutation, right? So this is due to G protein mutation. Now, because of this particular mutation, you don't have excess ADH, but what happens in these individual is there will be gain of function of the V2 receptor, right? So there will be gain of function of the V2 receptor. So that will be the problem in case of the genetic form or your familial form of the SIAD, right? Now, so what are the key clinical features here? You will have the clinical features mainly because of the hyponatremia. The volume status will be euvolemic. So that is the reason why in these patients, the blood pressure will remain normal. And these patients, there will be no ascites. And in these patients, there is no edema as well, right? You will have the clinical features of the hyponatremia. And the clinical features of hyponatremia is that there will be raised intracranial pressure, because in hyponatremia, there will be cerebral edema. And the features of raised intracranial pressure include the headache, there will be projectile vomiting, altered sensorium, the individual will develop seizures and coma, and finally death. So These will be the key features that you will have in patients with the SIADH, and that particular features are mainly because of the hyponatremia. And what will happen to the serum osmolality? The serum osmolality is reduced. And what will happen to the serum sodium? The serum sodium will be reduced. And what will happen to the urine osmolality? Urine osmolality is increased. And what will happen to the urine sodium? The urine sodium is increased, right? Now, if you take the investigation of choice, the investigation of choice will be the water loading test. Whereas in case of diabetes insipidus, it is water deprivation test. Whereas here, it is the water loading test. Okay. So what happens here? Now, whenever you give a loads of water for the individual to consume, what happens in a normal person is, in a normal person, right, in a normal person, more than 90% of the water is excreted out within 4 hours. That is what happens in a normal person. Whereas in patients with SIADH, less than 30% of the water load is excreted. Less than 30% of the water load is being excreted in patients with the SIADH. Why is that? Due to excessive ADH production, there will be excessive water reabsorption, and that is the reason why only less than 30% of the water is being excreted out, right? So this is about the water loading test. Then what are the causes of the dilutional hyponatremia? Here what you get in case of SIADH is euvolemic hyponatremia, right? The causes of dilutional hyponatremia includes the acute kidney injury and as well as nephrotic syndrome, cirrhosis of liver, and as well as the congestive cardiac failure. So in all these conditions, there will be increased volume of the fluid that will dilute the sodium, resulting in dilutional hyponatremia, right? And whereas in SIADH, as I have discussed, it is euvolemic hyponatremia. Now, if you take the symptoms in SIADH, just now what we have discussed, the symptomatology completely depends upon the hyponatremia. So, severe symptoms the individual will be having if the patient develops acute hyponatremia. If the individual develops acute hyponatremia, then this acute hyponatremia will cause cerebral edema, and that is the reason why the individual will be having clinical manifestations. Whereas, if this particular hyponatremia development is gradual in onset, right? If this hyponatremia development is gradual in onset, then the individual will remain asymptomatic, right? So what will be the features of your acute hyponatremia? That is projectile vomiting, confusion, seizures, coma, and as well as death of the individual. So if you take the labs of these patients, you will be having the serum sodium being reduced, and even the blood urea nitrogen is also being reduced. And what will happen to the serum uric acid? That is also reduced because of the dilution effect, right? But if you take the potassium levels, that remain normal because it's an intracellular ion. And in these individuals, there is no volume depletion. Okay. And what will happen to the urine osmolality? That will be increased. And serum osmolality, that will be decreased. And what will happen to the urine sodium? Urine sodium is being increased. So this is about your laboratory findings in patients with the SIADH. Now, in the management of the SIADH, if the individual is having a mild form of the SIADH, then just only fluid restriction, this will be the first line treatment, right? The fluid restriction, this will be the first line treatment. Okay. So the fluid restriction is first line mainly in case of the stable cases. And how much is that fluid restriction? That is nearly around 30 ml per kg per day, right? Around 30 ml per kg per day is the fluid that has to be restricted, and that is the first line treatment. If that too, like when the individual is like stable. Whereas in severe forms of the SIADH, you need to give hypertonic saline, right? Where you need to give 3% sodium chloride has to be given. Or if the individual is like severely symptomatic, then Vaptans are considered as the drug of choice, right? Vaptans have to be given in severe symptomatic hyponatremia. And whenever you're giving this 3% sodium chloride or whenever you're giving this Vaptans, what is that you need to do is you need to monitor the sodium. And this Vaptans like we have tolvaptan and as well as the conivaptan. Whenever you're giving this 3% sodium chloride or whenever you're giving this vaptan, what should be your goal? Your goal is to raise the sodium. And how much the sodium has to increase? The sodium has to increase by 1 to 2 milliequivalents per hour. And you should not do rapid correction. Once you do a rapid correction of the hyponatremia, the individual will land up in the osmotic demyelination syndrome, or there will be central pontine myelinolysis where the individual will be having weakness and as well as the quadriparesis. Now, if you take the discussion about these vaptans, what these vaptans do? These are vasopressin receptor antagonists. These vaptans, they block the V2 receptors. Right, these vaptans, they block the V2 receptors and thereby increasing the free water clearance. Right, thereby increasing the free water clearance. And we have two forms of vaptans. One is tolvaptan and the other one is the conivaptan. If you take tolvaptan, it should be given through the oral route, and the starting dose of the tolvaptan is around 15 milligram per kg. Whereas conivaptan, if you see, it has to be given through the intravenous route. Loading dose is like 20 milligrams, followed by that you need to give 20 milligrams per 24 hours, right? So this increases water diuresis by blocking the V2 receptors. That will be the action of these particular vaptans. Now, is there any role of diuretics in patients with SIADH? Usually no, we avoid diuretics. But in scenarios of pulmonary edema, so if the individual has developed like pulmonary edema because of the fluid overload, that is when you give this furosemide. Otherwise, we don't give this particular diuretics because diuretics themselves will cause the hyponatremia, right? And now suppose if it is mutation related SIADH, that means familial forms of the SIADH, you need to give the urea. Now, in case of the familial form, just now I have discussed, like what exactly happens? There is gain of function mutation in V2 receptor. Right, there is gain of function in V2 receptor. As such, there is no active increase in the ADH. It is just only gain of function mutation of the V2 receptor. Okay. So what is the treatment that you need to give in case of the familial forms? Is like you need to give the urea. Right, you need to give the urea. So that is what is the treatment in case of. So what is the difference between the classic SIADH and as well as the mutant form? In classic SIADH, there is increase in the antidiuretic hormone, whereas in mutant form there is only gain of function of V2 receptor, but the ADH levels that remain normal. Then followed by that, lastly, if you see the etiology that will be causing SIADH, the SIADH is observed in certain malignancies like oat cell carcinoma, then carcinoma of stomach, carcinoma of the esophagus, carcinoma of the colon, carcinoma of the pancreas, carcinoma of the lung, thymoma. Then in case of Ewing sarcoma, these are all malignancies where you can have this SIADH. Then we have the central pathologies like cerebrovascular accident, Guillain-Barré syndrome, multiple sclerosis, amyotrophic lateral sclerosis. These are the central pathologies that will be causing your syndrome of inappropriate antidiuretic hormone. Then we also have some drugs that will be causing SIADH, and these drugs include desmopressin. Then we have Vinca alkaloids, that is vincristine, monoamino oxidase inhibitors, selective serotonin reuptake inhibitors, tricyclic antidepressants. These are the drugs that will be causing the syndrome of inappropriate antidiuretic hormone, right? So this completes the detailed and quick discussion of this very important topic, syndrome of inappropriate antidiuretic hormone. Thank you very much.